look at what we're talking about. We're talking about Abacus, we're talking about ICER, we're talking about NCCN, we're talking about ASCO. What is that? Drug, 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 and drug. Now, I know it's really popular in the press to slam the companies and to focus on the drug price. The drug price is an issue of all the components of care. It is the most rapidly growing, but still I put that in perspective. And it's so refreshing to hear from someone who's getting the calls every day about the calls every day in terms of what's happening, is that it's a larger picture than just the drug. So if you look at it at the end of the day, it's not just about an Abacus tool or an ASCO tool or an NCCN, ICER tool about drug, 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 drug. It's about what's really important to patients, which is, yes, the drug is important, but it's these other costs as well.
Yeah, I fully agree with that. Maybe did you want to move to NCCN?
I definitely did.
I was sort of not to do your job, but
no, because I think that we're last conversation about we need an app for that.
Yeah.
And NCCN is about the closer you're going to get to an app for that.
Yeah, you love the grid. The grid looks great on an app.
Yeah, exactly. It's just a visual. All right, so do it.
Yeah, I'll just make a couple comments before your big finish on ICER, because I know that's where we're getting to.
I think we're going to run out of time.
What I'll say about the evidence blocks is, NCCN as an organization has really built an amazing brand on evidence, right? I mean, that's what that organization has done over time. The domains around the evidence blocks, the efficacy, the safety, the quality of evidence, the consistency of evidence, a lot of that, they've done much of that already, and they've been able to sort of provide guidance to the practicing community around what guidelines should look like relative to those things. I think the evidence blocks is the addition of that fifth component, which is affordability. To Ted's comment, I mean, this is really done so with a very myopic focus on drug cost. And I think, while I stated the brand that's been built around evidence, I think the evidence and the methodology behind how you get to affordability in these evidence blocks is still relatively sort of misunderstood, at least to me and a number of my colleagues. What they say and then ultimately the process for getting there and how many boxes ultimately wind up getting shaded in. For the most part, if you compare that to acquisition cost of the drug relative across the blocks that they've released, I think you see relative consistency, but there are outliers. And again, I think it's a somewhat of a narrow way to try and prescribe that fifth block and say this is what it represents affordability-wise to any one specific patient. What I really like is the intent is for that discussion, right? And it is not a calculator that ultimately spits out one number and says, well, you should look at this, particular patient, you're not gonna be able to afford this product. There's a number of things that conversation ultimately can drive to. If there's a sort of low ranking on affordability, meaning that the product is particularly expensive, let's talk about copay assistance, let's talk about patient assistance programs, the generous programs that a number of companies provide. Enhance that conversation, making sure that it's happening. Not all the way to Dr. Kologier's point around calculation of net health benefit, but a step in that direction.